Hello, my name is Johannes Waldschmidt from Würzburg University Medical Center in Würzburg, Germany, and we have presented data at ASH on our German experience with the efficacy of CAR T-cell therapy in myeloma patients that have been pre-exposed to bispecific antibodies. And the rationale behind this idea was that bispecific antibodies are a tremendously active class of drugs in the treatment landscape for multiple myeloma. And at the same time, we sometimes run into problems to safely bridge patients to a CAR T-cell therapy. On the other hand, available data suggests that bispecific antibodies may impair manufacturing of CAR T-cells, may impair CAR T-cell efficacy. And in this study, we now looked at 39 patients treated at 10 different hospitals in Germany. And the median line of prior therapies in this cohort was 7, so quite heavily pretreated, with a range between 3 and 13 prior treatments. And the rate of extramedullary disease was also quite high, with 42%. We first looked at efficacy, and in terms of efficacy, we saw a slight advantage for cilta-cel over ide-cel. Both were part of this trial, but cilta-cel induced a CR rate of approximately 40% and ide-cel just 31%. Apart from that, we could confirm risk factors that have been previously described, that is to say high-risk cytogenetics, extramedullary disease. But now the beauty of this study was really that we could dissect the pattern of how bispecific antibodies were given in the context of bridging therapy to ideally define the optimal position of bispecs in the context of CAR T-cell therapy for multiple myeloma. And this study basically gave us 3 big findings. One finding, the first finding, most important, is the efficacy of a CAR T-cell therapy is always better if you get your CAR T-cell therapy with a well-controlled disease state. For those that might not be familiar with it, so bridging, typically, there are some heterogeneous definitions, but we understand bridging as the time frame between T-cell apheresis and then reinfusion of CAR T-cells, typically 8 to 10 weeks. And we could find that the disease control state at the time of apheresis is not of tremendous importance, but at the time of CAR T reinfusion, you really want to have a controlled disease. And in our cohort, there were patients with bad bridging, suboptimal, let me call it suboptimal, and optimal bridging. So we had some patients that lost their control during bridging, and these patients had very poor outcome, and other patients could actually be induced to get good disease control even though they didn't have it at the time of T-cell apheresis. And this is the first finding. And then in terms of bispecs, we could stratify our cohort into 4 groups. So the first group was patients that have both been exposed to teclistamab and talquetamab before apheresis. Second and third group were exposed to either tec or tal, one of them before apheresis. And the fourth group was the one where we could actually avoid giving bispecs before apheresis and only gave it in the bridging. So that is to say after apheresis, before reinfusion. And this was the group that by far performed the best in our analysis. PFS not reached. The poorest PFS was in the group of patients that had been pre-exposed to both tec and tal before apheresis. And PFS in this group was around 4 months. And in between was this group of either tec or tal exposed patients before apheresis with a PFS roughly around 1 year. We believe in conclusion that this study shows that disease control before CAR T reinfusion is of tremendous importance, and bispecs may help in those patients where at the time of apheresis we might not have an ideal remission state, and then once T-cells have been collected, we are free to go with the bispecs, and the bispecs can help during bridging to induce disease control. There's one caveat though. We obviously also looked at teclistamab, and teclistamab is targeting the same antigen, BCMA, and we had 7 patients that had been exposed to teclistamab for more than 3 months. This is what we defined as long-term exposure to teclistamab, and 2 out of these 7 patients actually had a loss of BCMA, then moved into CAR T-cell therapy, and obviously CAR T-cell therapy didn't work. So in this respect, we would advocate for using talquetamab during bridging over teclistamab just to save BCMA as a target. But we feel that talquetamab targeting GPRC5D can be of enormous help to really set the perfect stage for CAR Ts then before reinfusion of CAR Ts.